So hello everyone, my name is Maisa, I'm a resident at Rambam Hospital. So let's start. So we have a 57-year-old woman who is complaining about pain in her left lower limb for about 7 months now. She even had local anesthetic injections performed 2 months earlier. And then finally she was referred to an orthopedic consult. The orthopedic doctor ordered x-rays as a first step, and here are her images. What we can see here is that we see a lesion, a lytic lesion in the midshaft of the left tibia. It is well defined, eccentric, and with a bit of expansion. So if we consider these radiologic features only, do you think this lesion seems benign or malignant? These features do suit a benign lesion. So if we look at these DD, what do you think is most likely to suit this lesion? Is it ossifying fibroma, aneurysmal bone cyst, adamantinoma, abscess, or none of the above? So ossifying fibroma and adamantinoma are in the running because both can be in the diaphysis of the tibia, but ossifying fibroma usually presents at a younger age group, typically 10 to 20 years old. And adamantinoma is usually multilocular. It can be locally aggressive with ill-defined borders and sometimes with periostitis, which is not the case here. Aneurysmal bone cyst usually is at the metaphysis and usually more expansile and in a younger age group. Abscess is an option, it could be, but in this case it was none of the above. It is important to consider when we're talking about 57-year-old patient, even if the lesion looks benign from its radiologic features, more thorough examination and more advanced imaging is needed to rule out other things. So this patient underwent a CT scan, and this is what we see. We see the lesion that we saw previously on x-rays in the left tibia, and here we can see that on the right side of the image we see another lesion which is similar but smaller in the right tibia as well. Here are axial views of the same lesions, and even more lesions were found, like for example in the proximal tibia and in the cuboid bone. All of the lesions were intracortical, lytic, and very well defined, maybe with a thin sclerotic margin. If we look even closely to the painful lesion on the left tibia, we can see and notice here that there's a fluid level inside the lesion, and it's accompanied with subcutaneous edema and intramedullary edema seen here on the right image. And in bone scan there was an increased uptake of this lesion. So now that we're talking about multiple lytic lesion in a 57-year-old woman, what do you think these lesions could be? So A, B, and C are the first 3 DDs that we put in multiple lytic lesions in this age, but since there's a fluid level, we the findings are not very suitable for these 3 DDs because we only found really rare cases of metastasis with some aneurysmal bone cyst changes, and we couldn't find any cases with multiple myeloma or lymphoma, and in this case it was other type of lesions. So the key to solving this mystery here was clinical correlation, and here are some more clinical clues to help us solve this mystery. This woman had 2 episodes of renal colic. She was constantly tired. She suffered from constipation, and she had anxiety and depression. And there's a known saying or phrase to summarize these symptoms. It's called stones, bones, groans, moans, and psychotic overtones. And all of these symptoms are symptoms of hypercalcemia, which this patient had. So now, if we try to connect all the dots, what do you think is the likely diagnosis based on all of this information? Is it A, hypopituitarism, B, pseudo-hypoparathyroidism, C, hyperparathyroidism, or D, hyperthyroidism? C is the correct answer, and this is these are her lab results. She had hypercalcemia, hypokalemia, hypophosphatemia, normal creatinine values, and high values of parathyroid hormones. And she went on a system EB parathyroid scan, and we can see an increased uptake in one of her parathyroid glands. And the final diagnosis is, what are these tumors? It's brown tumors due to primary hyperparathyroidism. So to sum up, brown tumors, or osteitis fibrosa cystica, is one of the manifestations of hyperparathyroidism. It is slightly more common in primary hyperparathyroidism versus secondary hyperparathyroidism, but considering since secondary hyperpara is much more common, most of the brown tumors are actually due to secondary hyperparathyroidism. Chronic renal disease is the main reason for secondary hyperparathyroidism. It causes parathyroid hormone secretion, which triggers osteoclastic activity and bone resorption. And in areas where bone resorption is is very rapid, these cystic spaces form. It is called brown tumors because it has high hemosiderin content. And it can occur in any bone really, but usually it's more likely to happen in the diaphysis of long bones. It's very vascular, and that's why it can be accompanied with edema, and it can be painful. And the main clue here for this diagnosis, other than hypercalcemia, is that it may have a fluid level. And in this case, this patient underwent surgery 2 months after the diagnosis, and but the pathology results were hyperparathyroid adenoma. And that's it. Thank you.